เอาละค่ะท่านต่อไปนะคะวิทยากรที่จะมาพูดเนี่ยคือดร.เวยหยางชองท่านเป็นรองอธิการบดีฝ่ายงานวิจัยเชิงกลยุทธ์มหาวิทยาลัยการจัดการแห่งสิงคโปร์นะคะท่านจะมาพูดในหัวข้อ Case Study Singapore Study Singapore Story นะคะ May next invite Dr. Wei Yang Chong Strategic Research Partnership of Singapore Management University. He's the Vice Provost and also the Senior Advisor of Health Economics, Ministry of Health, Singapore. Please give Dr. Wei Yang Chong a very warm welcome.
Hi everyone, thanks for inviting me to speak. I'm going to take a slightly different tack in terms of what I'm going to cover. I think you've heard about the issues of rising inflation, and of course there are also attempts by the SSO to try to, in a way, deal with that and to combat that as part of ensuring provision for everyone in Thailand, especially those who are otherwise not well covered by the health system. And of course, there are various areas that I think we are grappling with in the short run. But I guess what I'll try to cover a little bit more is also when we think about sustainability, we are looking at how we can innovate and how we can deliver value-based care. And in so doing, we are looking at actually not just how the payment is being made, but what we are paying for. Okay, so what we are paying for is potentially as important, if not more important, than how we are paying for it. Because if we are paying for treatment, then that's always going to be a lot more expensive. If we are paying for cardio-related diseases, for example, that's expensive. But if there's a way for us to help people manage their cholesterol levels and all the other sort of like metabolic disease biomarkers, there is potentially a much higher chance that we don't have to pay as much, and the system can actually work on the basis of capitation as opposed to the fee payment structures that we now have. So keeping that in mind, what I'll first talk a little bit about is the Singapore health system of today. Many people talk about the Singapore health system and how we have achieved probably good outcomes despite the fact that it's not a very costly system. I break it down to three main reasons why that's actually the case. I think we have focused a lot of our energies on training our healthcare workers, HCWs, the healthcare workers, well. So this includes not just doctors, but also nurses, allied health professionals, and so on. Because by training these people well, we get good quality service for the amount of money we are paying them. Second, we have actually well-run public health institutions, what we call PHIs, public health institutions. I know here you call it private health insurance, but for us PHIs is the public health institutions. So the public health institutions is actually what I'm referring to, and here they are well-run in the sense that there is efficiency in the system that ensures that each dollar you spend is spent well. Okay. Then finally, the one that I think Charlene spoke quite a lot about is actually the idea of the 3 M's, which is that we actually have a system where there is MediSave, where each individual saves a certain amount of money from their retirement savings that is dedicated towards spending into healthcare. And why do we divert retirement savings from our CPF into this thing called MediSave? Because spending on health today is a form of investment so that you don't have to spend so much in the future by becoming very, very ill. Okay? So we actually have MediSave, which is taking your own retirement savings to allow you to spend it on healthcare when you actually need to spend. That's the first thing. Second, we actually have this thing called MediShield Life, which is actually a national health insurance system that pools everyone. We make it quite difficult for you to opt out you can, but we make it quite difficult for you to opt out. The amounts are not large, but what happens is that it then covers you for the more catastrophic illnesses for which you may not otherwise be able to afford to pay. Okay, now, so the MediSave, if you think about it, is your own money that you saved aside that you can then use for the co-payments as well. Okay, but then what happens is that the MediShield is the insurance that then covers if above that co-payment you are not able to afford, we can then cover that. Finally, of course, if despite MediSave and MediShield you still can't afford, then a MediFund kicks in, and this one is needs-based. Basically, if you can't afford to pay, there is a fund that then steps in to help you to pay. Okay, but all this is premised on a well-subsidized health system, right? That the government actually puts in quite a lot of subsidies for, so that the cost, the ticket price of what the individual has to deal with is already lower than what is the real cost of the medical care. Okay, but I thought I wanted to emphasize this, the 3 M's that shape patient demand, because that's actually a large part of what insurance could potentially help to do, or it could actually go against that, right? Because in the end, the insurance system interacting with the payer system and the providers is part of the dynamics of determining what demand actually really is. So of course, in some sense, we look at our own system, we think that we have exhausted the key ingredients of improvement. So we are now turning in some sense to research, innovation, and technology to help us to make the next quantum leap in improvement. We see in the Singapore future health system a situation where each healthcare worker will be further augmented by what we think are the best and most appropriate technologies, so that each healthcare worker can give us more value. Okay, so that could be AI, it could even be robotics, it could be the use of diagnostics that help to stratify patients, it could be therapeutics which are more novel in nature, it could be the use of digital health technologies that mean that I do not need to have a brick and mortar. It means that I can actually reach a lot of unreached people, and to do so in ways which are actually potentially more cost-effective for the system. So just to give you an example for the digital health area, for example, it may mean that instead of trying to send a doctor into the home, I zoom a doctor into the home of the patient. That reduces the cost of the patient trying to come in to the hospital, and means that I do not need to have the doctor sitting in a room to see that patient. It may mean that I still rove a nurse into the community, but that nurse may be living in that community. Right? So there are some of these things that we need to think about. The second, of course, is that we are trying to create systems-level incentives to right-side care, right? And not just to run each institution well. So I think there's some attempt of that because of the capitation model you try to adopt. But we are taking capitation quite far to tell the hospitals that, look, we will give you an amount of money, and that amount of money means that you look after this group of people, and I don't care how you spend that money. If you spend more on preventive health, so that you spend less on treatment later, you keep the rest. Okay, so of course, this is not something that our hospitals necessarily know how to do very well yet, but we've set the incentive structure so that it becomes likely for them to want to do more preventive health than treatment, because we are giving them a maximum amount of money and telling them that going forward, we are not going to give you fee-for-service payments anymore. The third thing that we think a little bit like how I had the earlier chart, how we deal with each patient, I think will also be important. So we are looking at things like what I call the omics, which would be the genomics, proteomics, metabolomics, basically all the things that we measure about each individual so that we better know each patient and what works well for them and what doesn't work well for them. We have our electronic medical records that we are having, moving forward one single system across all the public health systems in Singapore, so that any episode of medical treatment that you have in one of our public health hospitals will be seen by any other doctor that sees you subsequently in the public health system as well. Okay, so one medical record system, so that first of all, we are able to properly characterize each patient and ensure what we call precision health, which is that because we know each patient well, we have enough data across the entire population to understand which treatment works better for which type of patients. We are much more effective for the dollars we spend on each patient. So I guess I wanted to talk about this because part of how we think about the future, because for us, we are building from a base today to look into the future because we are still having an aging population. And in order for us to continue to keep costs affordable, we must look at some of these technologies. But perhaps what I'm trying to motivate a little bit is to say that for Thailand's case, the question is whether you can leapfrog with these technologies into a new way of thinking about service delivery that is shaped maybe together with the insurance partners to ensure that in terms of how you deliver this health could actually be quite different from what may have been the traditional ways of doing so. So just to give you some sense of why I'm talking about some of these things. And of course, one of the things that we have done ourselves in Singapore, because we started off building the hospital system, and then we realized that as the population aged, we then needed to figure out how to provide more sustainably for our population. We have actually been on this, what we call the 3 Beyonds reform for almost a decade. Okay, this whole idea of moving beyond healthcare to health. Because healthcare is actually really sick care. You take care of someone who's sick. We are saying, no, the objective must be to help support each Singaporean to lead healthier lives. So how do we achieve that? How does a health system try to achieve that? Second, of course, is beyond hospitals to community. We don't want the person to end up coming to the hospital to get care. We want to push our ability to service them into the community so that either we catch them early or we prevent the disease from happening until much later. But in order to do that, I must reach them in the community because people only come to the hospital when they're ill. How do I go out to them before they are ill so that we are able to do preventive health approaches much better? And finally, of course, we had moved as a system to have a lot more emphasis on the quality of doctors and so on. And of course, naturally, doctors will find what we sometimes call a new shiny toy to use, which may obviously create better outcomes. But the question we ask is that, but what is the value? What is the better outcomes divided by the cost? And was that the best thing to have done for that individual? Now, of course, was it the best thing to have done for the entire population? Because if I do this for one person, does it mean that I don't have the resources to treat 9 more people? Or should I find another approach that allows me to treat all 10 people? Okay, so moving beyond the concept of quality to this idea of value, beyond the sort of like idea that I have a patient in front of me that I will treat regardless, to a concept of triage, which is that I have 3 patients in front of me. I have to figure out how best to treat all of them so that there's the best possible outcomes for all 3 of them. So as we had a decade-long movement of the 3 Beyonds, more recently, because of some of the advances in technology, we have now started to think, okay, building on the 3 Beyonds, how do we move to this whole idea of the 3 Ps in health? 3 Ps representing population health, precision health, and preventive health. So these are items that you may have heard of in one form or another throughout your own practice and so on. So maybe let me explain a little bit more what do I mean by each of them, because you may have slightly different perspectives of what these terms mean. The key concept of population health is that we take the entire population and we figure out how to maintain their health in the best possible way. In a way, because of the capitation model, these people are my responsibility as a health group, regardless of whether I keep them away from hospital or they end up in my hospital and I need to treat them. But that also means that there is an integration of care across the different possible providers. It could be in the hospital, it could be in the polyclinic, it could be in a single doctor in the community, and I should be indifferent between any of these things, but based on where care is best provided and most properly provided, I determine where the care should take place. Okay, now that's not easy because obviously the hospital and the polyclinic and the GP are under different governance structures. Okay, but how do we integrate that? The other thing, of course, is accountability, because it's very easy for us to say, okay, length of stay is X days. I take the guy in the hospital, I discharge him, so I satisfy the length of stay, but 3 days later he shows up at another hospital. Who is accountable for that? Right? So the accountability of care over time is important. And so if we take this whole population health approach, then we are able to achieve this idea that there is a certain responsibility for this population. But more importantly, if I'm accountable for this population, I begin to collect data about this population and to collect it diligently over time. Right? This creates a baseline for me to understand that population, what type of medical episodes they have gone through, what has been tried, what has succeeded, what has not. Is there a behavioral issue in terms of their ability to manage their own health? How do we help them in the best possible way? The second thing that we are trying to then develop is this idea of precision health. And of course, from Singapore's perspective, we realize that we are actually a bit of a combination of people from around the region, as far as China, India, but also the Southeast Asia region, which means that the genomics, the metabolomics, the proteomics of the people who live in Singapore actually represent, in some sense, the people in the region. Now, if you are able to understand how that affects disease progression, disease severity, that would actually mean that we can be much more precise in how we treat each of these people. Allied to that is then what I call the companion diagnostics, therapeutics, and vaccines that may be necessary as part of this ability to be precise in the way we deliver health in Singapore. Finally, as I get the population health structures in place, we are able to collect data about individuals over time. We are able to understand better the disease progression of the different groups of people and how well they react to different types of treatment, which is the precision health part. I will also know then who are the people who are more susceptible to illness or to bad disease outcomes, those which are despite, for example, when people contracted COVID, some people were perfectly fine, others fell sick very fast. How do we understand which type of people fall sick, which type of people don't fall sick? And if I understand that, I will know how to prioritize vaccination, I'll know how to prioritize treatment, I'll know who can be treated at the community level, who I need to bring into the hospital immediately. Our rule of thumb during COVID, because we didn't know better, was elderly, please bring all of them in. Those who are not elderly, please stay outside. I don't think anything's going to happen to you. But then there are a few of them who died from heart failure. I mean, that happened in reality, right? So we didn't know it well enough, but we believe that in the future, that's probably where we need to get to. Because once I understand these things, the preventive health then becomes much easier for me to do, right? If I know that a particular group is more susceptible in a particular disease area, I will bring them in for screening a lot earlier. I will even collect digital biomarkers of their activities so that I have a better sense of are they managing their disease properly. And even better, because of our digital technologies that we can employ, we can actually nudge their behavior so that they stay healthy and don't actually come in to consume healthcare resources. Okay? So I know this may seem like a bit of a, well, the guy is talking about the future, he's talking about something that doesn't seem achievable, but I just wanted to maybe help you to push your boundary of thinking to say, are there ways for a system like Thailand to think of health in this way so that sustainability actually can be better achieved in the longer run? But I don't want to be, how should I say, I'm realistic as well. It is not easy to achieve this 3 Ps. And here I talk about a few of the things that will need to be sorted out, that will need to be well developed in order for us to be able to deliver the 3 Ps successfully. So first, in terms of this idea of population health, in order for us to capture the data of individuals over time across the entire system, we need to think about what is the data architecture, the technical standards, and the governance of this data as it gets collected by the system. So here you have to think about what is the role of the insurance, what is the role of the government, what is the role of the hospitals, what is the role of the individual, and how do you ensure that when we collect that data, it is not used against, let's say, the individual such that they don't want to contribute the data into the system anymore. Okay, so that's one aspect. The other one, of course, is that whether there are then ways for us to use what I call more digital or AI type methods to use this data to help us to push care protocols into the community so that you don't need necessarily very experienced doctors or even doctors, maybe a nurse can go in and already provide very good advice because they are helped by the AI that has studied the data from the entire population and told them that this person in front of you only needs this. The second part, of course, is that for the precision health, we probably need much stronger population stratification approaches, as well as what I call post-market surveillance structures. Because what happens if, let's say, I think that there are certain genomic or underpinnings of a particular disease, then I may then recommend a particular treatment. But that's based on historical data to date. After treatment, how that person turns out, does the disease indeed progress better, needs to be monitored. And based on that monitoring, this stratification further updated. Right? So the precision health approach requires a responsibility to keep tracking whether or not what you are recommending for stratification is accurate or not. Now, if you think about it, we are probably all aware of this thing called the Framingham Heart Study. Actually, that was just 5,000 people over, yes, a long period of time, but that now shapes a large part of our clinical protocol today. And you have to ask yourself, why has not been updated, and why should we take that as gospel truth? And why are we not monitoring what's actually happening in our population in order to actually ensure that each intervention that we do is actually more accurate than before? And finally, of course, in the realm of preventive health, and here again, maybe that's where it's most relevant to this particular conference, as we have what I call the more population stratified, the population stratification, then the diagnostic protocols associated with that stratification becomes important. And often that will be shaped together with the insurance players. Because if indeed I stratify the population and these are higher risk group, insurance should be much more prepared to pay for these people's diagnostics because it means that the likelihood of a more catastrophic claim later reduces drastically for you. But if the insurance payer is not able to manage that or handle that kind of claims on the basis of stratification, then you lose that opportunity. You also need to have maybe a more actually sound insurance and payment discount system, which means that today, if you were someone who went for your checkups regularly, somehow I give you a discount in terms of how much insurance premiums you might need to pay. And it may not be insurance premiums. I'll give you an example that I heard, which was quite interesting. This was actually rolled out by BGI. And what they had done was that they had a program for insurance against cervical cancer. Okay? What they did was they collected a baseline level of payments, not a very high amount, and guaranteed that any cervical cancer treatment they will fully pay for, as long as after that, every year or every fixed duration, you submit a pap smear test. Sometimes the medical adherence is more important than the insurance payment, because that medical adherence means that I catch it early, I catch it at a stage where it's completely treatable, and indeed, if in the off chance somehow something went wrong, I will take the rest, right? That for this particular individual that I somehow didn't catch in time. So just thinking through some of these things and how to think about how we structure the financial and the clinical protocols together, I think will be important. And finally, of course, as we do a lot more of these things, ensuring that the incentives and the audit systems are aligned in terms of ensuring that this system is truth-telling. And more importantly, because the nature of preventive health is that you spend today so that you avoid cost tomorrow, it may mean that payment may have to be paid over the course of the next few years when you remain healthy. But if so, the product is consumed today, benefit is being accrued over the next few years, some sort of financial derivative may be necessary in order for the market to clear. Okay, I know these are relatively difficult concepts. I leave this in your mind to think about. It is nowhere near to being achieved, but I believe that it is the future of where health is going to go. It is where Singapore is thinking about how do we bring this together, and then we are happy to work and walk this journey together with our neighboring colleagues. And finally, of course, I just wanted to show this last slide, that in structuring all these programs and thinking about health in a different way, really, we think that that's the way that finally all of us can achieve the UN SDG goals for the Asia-Pacific region. Thank you.